So, without further ado, let's jump in. When we think about immunosuppression, that is determined in, let's say, a somewhat holistic approach. You try to make an early decision about what is the immunologic risk of this donor and recipient pair, and then design an immunologic strategy driven by that principle. Okay, so if I have patients who have been transplanted before or have lots of HLA antibodies, and that would be captured by a higher panel reactive antibody, or an immunologic cause of ESRD, such as lupus nephritis, or of African descent, those would be higher immunologic risk. And so those would typically warrant a more aggressive immunosuppression strategy. And that strategy begins with induction and maintenance and concludes maintenance. So we think of induction and maintenance based on an estimate of the immunologic risk of this donor and recipient pair. Okay. And then we make a decision on induction and maintenance therapy, not in silo, but with that overall assessment governing our decision. So when we choose between the available induction agents, we can be driven by that determination of what is the immunologic risk and make decisions about whether somebody needs a more heavy-handed induction approach, which typically involves polyclonal induction. And we would even go further to say this is lymphocyte depleting polyclonal induction. I'll make sense of what those terms mean with, for instance, thymoglobulin at full dose. Rarely do we use this older drug, horse-derived anti-thymocyte globulin. Just as a quick aside, these agents are polyclonal because they're messy drugs. They are created by taking a human thymus, putting it in a blender, sucking it up into a syringe, injecting it into either a rabbit for thymo or a horse for ATGAM, and then that organism produces antibody to that human origin antigen pool or soup, let's call it. And then that is used to create this polyclonal induction agent, meaning there's antibody to a lot of different things, including cell adhesion molecules, lymphocytes, platelets, macrophages. You are creating, it's a dirty drug. It has lots of different targets, okay? Because I just ground up a thymus, injected it into a rabbit or horse, and recovered all of the antibody that's made by that rabbit or horse, okay? As you can imagine, that may cause immune infusion reactions, including a hypersensitivity reaction that is serum sickness, because these are, again, non-human immunoglobulin that's derived from a rabbit or a horse. If you happen to, have a time in your life where you were cuddling with rabbits as a pet or something, it's conceivable you may have preformed antibody to the rabbit, and you can have a serum sickness reaction, either because I had preformed antibody from a prior exposure, as I've somewhat provided a silly example of, or I've gotten thymo before and I started producing antibody to the various rabbit-derived antigens that are present in that soup that I've recovered from the organism. Okay, so the dosing is typically 1.5 mg per kg. Where I trained, they actually bumped it up to 2 mg per kg, and a full dose would be considered 6 milligrams per kilogram. So that would be either 4 doses of 1.5 mg per kg or 3 doses of 2 mg per kg, which is an off-label use or dosing, just to try and shorten the hospitalization time. but it seems to be reasonably safe. At least that was my experience as a fellow at WashU. And again, it can cause some various cytopenias, as one might predict, and you might hold a dose if you develop leukopenia or thrombocytopenia. Again, infusion reactions can occur acutely or in delayed fashion weeks later as a serum sickness, days to weeks later. And keep in mind that the effects of thymo might be detectable by sophisticated methods 1 and even 2 years out. So that's why I'm reiterating, you make determination or decisions about your strategy for induction immunosuppression as a holistic decision about immunologic risk. You're not going to do that. If something affects your T cell populations, even 1 and 2 years after transplant, the thymo that you're giving is actually affecting the intermediate and long-term outcomes of your patients, not just the first few months post-transplant. Okay, I won't belabor the horse-derived ATGAM, except to say that in a randomized controlled trial, it seemed to be inferior to thymoglobulin in terms of rejection rates in the renal transplant setting. Okay, so we don't usually use ATGAM unless somebody has a reason they can't get thymo. Okay, so again, this is polyclonal lymphocyte depleting agents. Now let's talk about monoclonal agents, some of which are lymphocyte depleting, others that are non-lymphocyte depleting, the anti-IL-2 receptor blockade, okay? So the classic monoclonal lymphocyte depleting agent is Campath or alemtuzumab. There used to be more enthusiasm with the use of this drug in transplantation. It's fallen off, and the drug company has become more restrictive in its use for that off-label use. It is an antibody to a specific antigenic target, CD52. It's not a dirty drug. Again, it is a targeted monoclonal antibody to the CD52 cell surface molecule. That CD52 molecule is present on a wide range of immune cells, including T cells, B cells, and macrophages. In fact, some studies that have documented rejection after receiving Campath show that many times it's a plasma cell rich rejection because the T cell, B cell, and macrophages are unavailable for rejection because of the profound depletion that results from alemtuzumab in those cell populations. It's an easy drug to give. It can be given peripherally. I glossed over the fact that thymo can cause a phlebitis, and so is typically given through a central line or a fistula. However, it can be given peripherally at slower infusion rates. I should, tweak this. It's not always given through a central line or through a graft or fistula, but alemtuzumab is easy to give peripherally, okay? It again does result in prolonged lymphocyte depletion and is a potent immunosuppression agent, and therefore was one of the drugs that was commonly used in protocols that were atypical. That, again, remember, we're thinking about immunosuppression holistically. If I do something in the induction phase, it absolutely can affect my strategy for my maintenance phase. For instance, if someone was a relatively low immunologic risk again, right, was not a retransplant, did not have high PRA, I might say, I'm going to give you alemtuzumab or thymo, and then I'm going to run a steroid-free maintenance strategy or minimize calcineurin exposure. Give you, for instance, a steroid plus a mTOR inhibitor. So that's how, again, these crosstalk between induction and maintenance is something that is commonly done. Okay, they're not siloed decisions. Basiliximab is it's a monoclonal antibody. It's non-lymphocyte depleting. It's blocking the IL-2 receptor. Okay, and therefore blocks the pathway for expansion of my T cell population, which is often driven by IL-2. That's a simplistic view, but a T cell that's activated can, a T cell population that's activated can be expanded through the effects of IL-2. And so if I block IL-2 with basiliximab, I simplistically am blocking the expansion of this and activation of this T cell population that might be involved in rejection. This is considered light touch induction. Okay, so you would not use basiliximab in an individual who was, or a transplant that was deemed high immunologic risk. Okay, this is easy to dose, however, in terms of low rates of infusion reaction, can be given peripherally. Again, it's not a potent immunosuppression agent, including what has been found in randomized controlled trial data in moderate risk patients. There is an increased risk of rejection rate, although there's less infection rates when compared to thymoglobulin. Okay, so higher rates of rejection, less infection with the basiliximab, the anti-IL-2 receptor. We don't use OKT3 much at all anymore, but it is of historical relevance. It was one of your earliest lymphocyte depleting agents, monoclonal antibody to anti-CD3. You may recall CD3 is a T cell surface antigen, and so you would expect to see T cell depletion with this drug. It was a pretty tough drug to give. There was higher rates of infusion reactions, including capillary leak, causing pulmonary edema, and so you have to make sure that your patient was not very volume expanded. You'd also give pre-medication prior to the infusion. That would be carefully done because of those risks of infusion reactions. Okay, moving on to maintenance immunosuppression. Okay, the big picture view again. Define immunologic risk, make a decision about induction in combination with your plans for maintenance therapy. Okay, what are my maintenance therapy agents? Corticosteroids would be usually part of standard immunosuppression. So we usually think of standard maintenance as involving corticosteroid, calcineurin inhibitor, and an antimetabolite. Okay, so that's where and that antimetabolite is typically going to be mycophenolate most commonly. All right, that's your 3-drug maintenance immunosuppression that is most common in renal transplantation and even in non-renal transplant. Okay, so moving through corticosteroids, there's a variety of variation. There's a great variation across centers. So no way should you be considering this as standard for all transplant centers. Typically, it involves some amount of solumedrol dosing that starts in the OR at the time of the transplantation itself, and then a fairly rapid taper in prednisone, such that by discharge, many patients are on just 20 milligrams of prednisone at discharge, and then knock it down by 5 to 10 milligrams, usually 5 milligrams per week, something like that. Maintenance of 5 milligrams per day is usually part of standard immunosuppression that is considered continued indefinitely. To give you a sense for how that compares to normal physiologic glucocorticoid doses, We think the normal physiologic dose, if you were essentially adrenally insufficient, would be around 7.5 milligrams of prednisone. In hydrocortisone, that would be roughly 10 and 5, a total of 15 milligrams a day. But when you have negative adrenal function, this is more than normal. Okay, so giving 5 on top of native adrenal function, although you'll suppress some of that, is still more than the normal individual. So one might expect a higher rate of osteoporosis, weight gain, those sorts of things. Okay. You might consider steroid withdrawal or steroid avoidance as alternates to the standard practice of steroid dosing in transplantation. What do these mean? Well, steroid avoidance is, I would say, the more common strategy. Okay, this is where you give Solumedrol intraoperatively, you give some prednisone in the immediate post-op period, but essentially by the time of discharge, they're on no steroids. So that would be essentially considered a steroid avoidance protocol. Okay, if you were going to do that, you would not use basiliximab induction. You would not use that in a high immunologic risk pair. Okay, if it was low immunologic risk and you were committed to thymo, you might consider a steroid avoidance protocol. Okay, so again, think of the net immunosuppression, inclusive of induction and maintenance, when you're considering these strategies of immunosuppression. Okay, this may, as I mentioned, is usually paired with real induction. There may be this has been looked at in randomized controlled trials, steroid avoidance protocols, and has shown higher rates of rejection, okay, but no differences in intermediate term outcomes, okay? So with steroid avoidance, it's clear you have higher rates of rejection. Those rejections can typically be reversed readily. And in that randomized controlled trial, if you were randomized to steroid avoidance and you had a rejection, you were placed on steroids. Okay, so you move from a steroid avoidance to a standard protocol. Okay, so again, steroid avoidance seems to be okay for low risk patients. And then if you have a rejection, you end up being on steroids. Okay.
What percent of patients typically have rejection?
I'm sorry?
What percent of patients have rejections in this?
I don't have that number off the top of my head, but it wouldn't be like 50%.
Okay.
It was something like 20%, 15%. Okay. It was not the preponderance of patients. Okay. It was still a different, it was still, a net reduction in steroids in the steroid avoidance arm. Okay. And then let's review one concept that is important in understanding transplant immunology broadly. And I think I have this somewhere in the field guide, if you have a rejection, but you recover to near normal serum creatinine, okay, near baseline serum creatinine, or within 15% of your previous baseline, that doesn't seem to, in the early phase, early rejections, where I recover back to within 15% of my previous serum creatinine, those don't seem to translate into worse long-term outcomes. Why would that be? Remember, again, in transplant immunology, you are trying to understand that you may recognize non-self, and you can then say, ignore that. And you can do that perhaps by modulating co-stimulation. Okay, I recognize non-self. Some people also describe this as, in some arbitrary nomenclature, signal 1, signal 2, signal 3, but I might be a T cell, okay, with a T cell receptor, okay. I am recognizing non-self, okay, through a HLA molecule, class 1 or 2, binding non-self antigen, right? I make a decision now as a T cell based on whether or not there is co-stimulation, okay? And if I'm an antigen presenting cell, I have something that interacts with this co-stimulation pathway, okay? And then I can say, if I block co-stimulation, I can recognize non-self and then say, do nothing, okay? Or tolerate this. I'll use that terminology, okay? That's called tolerance. I recognize non-self, but tolerate it, okay? Or I can recognize non-self and I can react to that, okay? The presence of interleukin 2, okay, might modulate my response, right? If I have high IL-2, it would shift towards this direction of reaction and expanding T cells, okay? That's why blocking IL-2 is another way we modulate response. We can block co-stimulation, we can block IL-2, and then we can block this part of this reaction is proceeding through cell cycle multiplication, okay, cycling, okay? And simplistically, when I give an anti-metabolite, I'm blocking this phase of the immune response, okay? When I'm giving you azathioprine, mycophenolate. Also likely when I'm giving you an mTOR inhibitor, okay? I'm in broad strokes. mTOR inhibitors are dirty drugs. Okay, they do a lot of things, and that's why they have a lot of side effects. But simplistically, I'm telling the cell stop. mTOR is a old pathway that is expressed by fungi. mTOR in broad strokes says my cell exists in an environment of feast or famine, okay? And it's part of the signaling cascade that says there's nutrients that are plentiful, let's start revving up, or there is deficiency, let's shut down and go quiescent. mTOR inhibitors are basically, in broad strokes, saying don't multiply, go silent, okay? Because you're in a state of nutritional deficiency, okay? That's the broad strokes of transplant immunology, the tools that we use. The calcineurin inhibitor, which I haven't put here, is, I've run out of room, part of the pathway of reactivity, okay? Let's just move to different spot, okay? Here I am in the nucleus, okay? My cytoplasm, my T cell receptor, okay? There is calcium, intracellular calcium that increases in response to T cell activation. That increase in calcium binds to a molecule called calmodulin, okay? That interacts with a molecule called calcineurin, okay? That affects nuclear transcription, okay, through a pathway called NFAT, okay, nuclear factor of transmission, or transcription, of activation of transcription. Okay, so when I use a calcineurin inhibitor, I am inhibiting this process of T cell activation, which involves transcription. Okay? When I give you a calcineurin inhibitor, so like cyclosporin, it can bind with intermediates cyclophilins. When I give you FK or tacrolimus, it binds with another calcineurin binding protein called FK506, or FK binding protein, excuse me. FK506 binds to that. These are some of your intermediaries in this process, okay, of interacting with calcineurin, inhibiting calcineurin. Calcineurin is a phosphatase. It takes phosphates off of proteins, okay? So you're inhibiting calcineurin's phosphatase activity. Okay, in broad strokes, you should know calcineurin biology, okay? It becomes relevant as we discuss the effect of calcineurins on sodium reclamation in the distal convoluted tubule. Sodium, let me say, sodium chloride co-transporter in the DCT, the same transporter you inhibit with diazides, its activity is increased when it's phosphorylated, okay? So calcineurin inhibitors, which inhibit a phosphatase, might be predicted to activate sodium chloride cotransport, the phosphorylated form, okay? Which causes hypertension and hyperkalemia, the effects of calcineurin inhibitors. Okay, that's anticipating a conversation we're going to talk about later. That's why I think, even though there's a lot to digest here, you should know basic calcineurin biology or calcineurin inhibitor biology. Okay, I thought about bringing in some things from the internet and some other figures that I've made, but let's use the chalkboard. Okay, so again, calcineurin is a phosphatase that is involved in activating this NFAT pathway, a transcription factor. Okay. And we've talked about the IL-2 where it interacts. Okay. Any questions about this overview of immunosuppression? Again, T cell receptor binding to HLA molecules and an antigen. We've talked about that. Antigen presentation, co-stimulation, cell cycle progression. All of those are things you should understand as you're understanding the tools you use for treating transplant patients. We good with that? Okay. Cyclosporin has, a variety of different targets based on the transplant center. Here's a few considerations, but again, vast variation. Usually, I think if you want to take one number away from this, is a typical cyclosporin level that is in the therapeutic range is somewhere between 100 to 200. Maybe that's the distillation of what I'll take from this. Too many words. Okay, 100 to 200 is generally considered a therapeutic level. Now, if I'm in the patient who's 10 years down post-transplant, has stable allograft function, or has evidence of calcineurin inhibitor toxicity, a level of 50 might be sufficient. Okay, less than 100 would be a target there. There is a literature for monitoring 2-hour peaks for cyclosporin. I'd say that's atypical, but some people monitor peaks. In general, we're using 12-hour troughs to dose cyclosporin and tacrolimus. Okay, that's really important. You have to educate your patients. It's common that patients make mistakes on the troughs and you get an erroneous level. And if you haven't asked the patient, was this timed correctly, you may make bad decisions. Okay, so always, before you make a decision based on a level, verify it's a 12-hour trough. Or in some cases, you might want to follow 2-hour peaks. Only for cyclosporin, that data is really weak for FK. Okay. There is occasion where you might give continuous cyclosporin. The most common place that I see that is in a patient with GVHD in the BMT unit with severe mucositis. Okay, so cyclosporin or tacrolimus are also used to treat the immune response of graft versus host disease, a BMT patient with an allo transplant who's now having, severe mucositis, hepatitis, pneumonitis, all of the possibilities. Okay. We now use most commonly this microemulsified form. The brand names are Neoral or Gengraph. The oldest calcineurin inhibitor, the first calcineurin inhibitor that was developed was this molecule called Sandimmune. Okay. Sandimmune had a lot of complaints from patients. It apparently smells like skunk. It is poorly bioavailable. It's a very lipophilic molecule. It was often said that you should take this medication with a fatty meal or chocolate milk, full fat, because you need that squirt of bile acid in order. Remember, bile acids help you break down lipids, right, and make them more soluble. So that was one of the everyday experiences of transplant patients in the early days of cyclosporin. Okay, but the beauty of this microemulsified form, emulsification is just taking fat, making it into tiny droplets, right? Mayonnaise is an emulsion. Okay, so that's what this is: taking a fat droplets and making them tiny little droplets. So it's easily bioavailable, not so variable. You don't need a squirt of bile. Okay, so those are the drugs that we typically use now. If you give continuous infusions of cyclosporin IV, you have to give much less of it. Okay, so this gives me an opportunity to talk about the calcineurin inhibitor metabolism. So calcineurin inhibitor metabolism is through hepatic or through P450 enzyme systems. Okay, we typically think of the dominant one as the CYP3A4 system. You have a lot of cytochrome P450 enzymes. The CYP3A4 system is the dominant system for calcineurin metabolism and mTOR inhibitor metabolism. And gosh, I'm blanking on the name of the lupus drug since I don't prescribe it much. It'll come to me. The modified cyclosporin that's used for lupus nephritis. But you have poor P450 enzymes not just in your liver, but also in the enterocyte itself. So you have the CYP3A4 system there, 3A4, in the lumen of the gut as well. Okay. You also have, I'll anticipate, this multi-drug resistant pump, this P-glycoprotein. Okay. P-glycoprotein is a protein that is involved in pumping toxins out of cells, including chemotherapeutic agents. So this is one of the pathways of cancer resistance to chemotherapy. It is also a part of the clearance mechanism of multiple metabolites and toxins and drugs in pharmacology. Okay, so P-glycoprotein is one way in which your hepatocyte pumps drug out into the bile. Okay, that'll be relevant as we talk about the effects of cyclosporin on mycophenolate. Okay, but you have P-glycoprotein in enterocytes as well as hepatocytes. Okay, so one thing that I'll say as a punchline: calcineurin inhibitors don't depend on kidney for clearance. Okay, so if you have renal insufficiency, you don't need to lower the cyclosporin just to keep your levels right. You may want to lower the cyclosporin because you're worried about nephrotoxicity and renal insufficiency, but not because you're worried about reduced drug clearance. However, if you give the classic fluconazole, an inhibitor of a CYP3A4 system, you absolutely need to lower the calcineurin inhibitor dose, okay? Or if you develop hepatitis, Okay, you may need to lower the cyclosporin or tacrolimus dose or rapamune dose. Okay, all of those are, again, predicted by the fact that CYP3A4 system is the main clearance mechanism, as well as P-glycoprotein for calcineurin inhibitors. Okay? All right. Tacrolimus, let's get through the dosing, and then we'll reinforce some of this pharmacokinetic information that I'm covering. Dosing for tacrolimus, I've given you a rough estimate. So usually the dose is somewhere between 2 to 5 milligrams BID. When I'm starting calcineurin inhibitors or tacrolimus on a patient in GN clinic, I'm usually starting at 2. I don't really base it on weight because there's so much variance in P450 enzyme activity. There's some patients who are literally on 0.5 milligram BID and get a level. There's others that are on 7 milligrams BID, and you really can't predict that based on the size of the patient. So I usually start at 2, and then I just titrate based on levels. Okay. Again, there's a lot of, various levels that a center may choose. You can say that a usual therapeutic range is somewhere around 5 to 8. 3 to 7 comes from an important study that you should be aware of called the Elite Symphony trial. This is a study in transplantation that is one of the largest randomized controlled trials in transplantation, looking at outcomes of patients based on a variety of different maintenance immunosuppression strategies, including high-dose cyclosporin, low-dose cyclosporin, low-dose tacrolimus, and rapamune. So there was, I guess that comes out to 4 different arms. And the arm that did the best was the low-dose tacrolimus arm with a level targeting 3 to 7. Okay? The detailed view of that is that most patients were around 7. Okay? So, you might say a reasonable target was around 5. In real life is around 5 to 8. Okay? There are not many who are going to run 3 in the first 6 months. Most people would not be comfortable with a 3, and most transplant nephrologists wouldn't want to run a 3 in the first 6 months. 3 might be fine at a year, 2 years post-transplant. Okay? Once again, you will give less of it if you're giving it intravenously. I guess I didn't emphasize this point. If metabolism of the drug is in the CYP3A4 system and that is present in liver and enterocyte, if I'm not giving the drug in the intestine, here's my little pill, okay, where metabolism is occurring here, metabolism is occurring after I traverse the portal circulation here, I'm giving it to you IV, then you would have to reduce the drug, right? The dose, because I'm having less of this, let's call it first pass elimination when I'm giving it IV. You can also give the drug sublingual, okay? It's a capsule, you can open the capsule and put it under the tongue. And also you need to reduce the dose because it's going straight into the circulation. You're not having that first pass clearance at the enterocyte and liver. Okay, so hopefully it makes sense why you need to give the dose, a reduced dose, maybe half the dose when you're giving it IV or sublingual. Okay, there are once daily slow release formulations. Astrograph and Envarsus are those names. They lower the peak concentration. You typically follow the same trough for those drugs. Okay, peaks might be associated with that higher tremor, okay, that patients can experience with calcineurin inhibitors, those higher rates of tremor. So some people say the main advantage of these once daily dosing are in the ease of dosing as well as perhaps some less neurotoxicity. Okay. Pharmacokinetics, I've talked about many of these things, P-glycoprotein and CYP3A4 system. One can use that knowledge to predict drug interactions. This is a highly testable and clinically relevant area of transplant medicine that you should, really study. Okay, so drugs that inhibit the CYP3A4 system include DILT and verapamil, okay? Nicardipine is here, but it's a very weak inhibitor. The biggest ones are these non-dihydropyridine calcium channel blockers. The dihydropyridines are typically minimal in their interaction. DILT and verapamil, definitely. And sometimes that's leveraged when your patient's taking 8 milligrams BID of tacrolimus. You can put them on DILT and bring down that dose so that they're not taking so many pills. Some resource poor areas leverage that as well as a way to get by with less tacrolimus. Azoles would be predicted to lower this. Erythromycin and clarithromycin inhibit CYP3A4 system. Notice azithromycin does not, the most commonly prescribed macrolide, right? You don't typically lower the calcineurin for a Z-Pak. Okay, omeprazole, lansoprazole, weak. PPIs are weak interactors. Cimetidine, not so potent. Amiodarone, not so potent. Protease inhibitors, most protease inhibitors, very potent inhibitors, including the protease inhibitor ritonavir, which is used in Paxlovid. Okay, Paxlovid is two antivirals. The ritonavir is essentially a boosting agent to reduce or increase drug exposure of the other. I'm forgetting the other antiviral that's part of the Paxlovid package. Okay, protease inhibitors, really potent inhibitors. Grapefruit juice is another inhibitor. Fatty foods with cyclosporin can increase cyclosporin levels through that effect on bioavailability, okay, especially with Sandimmune. Empty stomach with tacrolimus also seems to increase the drug exposure, which explains why when you bring a patient into the hospital, often you have to lower their tacrolimus dosing because they're getting their dose at like 6 in the morning when they haven't been served breakfast. So often in the hospital, you reduce tacrolimus. Don't forget, when they go back and discharge, they probably need to go back to their home dosing of tacrolimus. So just because levels or dosing decreases in the hospital, you have to keep in mind that when they return back to their usual routine, your bias should be, unless something else has changed, right? They're on now diltiazem or an azole, that your bias should be go back to your home dose when you go back to your home routine, and we'll check a level. Any liver disease would be expected to raise FK levels, raise cyclosporin levels, but renal insufficiency would not. Okay? Questions about that? Okay. Decreases in cyclosporin levels are with your P450 enzyme inducers. Rifampin is one that we run up against when certain, tuberculosis, or if somebody's getting, meningococcal prophylaxis is another instance in which we use rifampin and, a few others as a synergistic medication in certain severe Staph aureus infections. Phenytoin, carbamazepine. We recently had a patient who had Bartonella and was getting rifampin long-term for that. And she was on be on higher doses. Okay, so these anti-epileptics, carbamazepine, phenobarbital, and dilantin also would be expected to raise the need for cyclosporin and tacrolimus, or the doses. Okay, St. John's wort is a herb that may also induce P450 enzyme. That is also, I'd say, a board question. Grapefruit juice, St. John's wort can be board questions. So we tell our patients don't take any of those. Okay.
Have you ever, if someone came in with severe calcineurin toxicity, have you ever given one of these drugs to lower the levels?
That's an interesting question. So I had a patient, the question is, what about using a P450 enzyme inducer in a patient who comes in with severe toxicity? I considered it. Okay, I would not say that I've used it. We had a patient who was placed on a I did it. It's my mistake. I'll fess up. A patient who was on a protease inhibitor for HIV also had lupus membranous, and we put her on a once daily tacrolimus. And even then, she came in with calcineurin toxicity at a level that was undetectably high, something like greater than 30. And in that case, and it stayed that way for quite a while. And so in that case, we considered using a short-term carbamazepine, which would probably be the least, I guess, toxic of these P450 enzyme inducers, but we ultimately did not. All right, some people have also, this is sort of a tangent, but leverages the same knowledge. Some people have considered using P450 enzyme inducers for severe cases of vitamin D toxicity. Vitamin D is also a steroid hormone that is metabolized by the P450 enzyme system. Okay. Effects on other drugs. Cyclosporin can increase statin levels by inhibiting the CYP3A4 system and the P-glycoprotein, as well as inhibiting some organic anion transporters. But the clinical relevance of this, especially for, well, I guess I've modified this already. I used to have here that tacrolimus does this as well. In fact, when I was a fellow, I was taught, even on FK, your Lipitor needs to be reduced by half. Since my fellowship, there's been some pharmacology studies that show, yes, there's similar effect of tacrolimus on CYP3A4 metabolism of statins that are metabolized by the CYP3A4 system. That's not all of them. Okay, I guess I've said that here. The statins that are not metabolized by CYP3A4 is fluvastatin, pravastatin, rosuvastatin, and pitavastatin. Okay, so you'll see patients who are on protease inhibitors in HIV patients that might be using Crestor preferentially for their dyslipidemia because it has less of it's not metabolized by the CYP3A4 system. Okay, that is inhibited by the protease inhibitors. Okay, so again, I used to lower a atorvastatin, lower a simvastatin in a patient on FK. You probably don't need to do that. You do need to do that for cyclosporin because it also has effects on P-glycoprotein, on organic anion transporters that inhibits the metabolism of all statins, okay, including fluvastatin, pitvastatin, and rosuvastatin. The interaction is less, but it still does interact with those other statins. Okay. Yes, I've said here tacrolimus interactions on statins is much less. Okay. Now, cyclosporin's inhibition of P-glycoprotein will be predicted to lower mycophenolate exposure. Okay, let's talk about that. I can use this as well. Okay, so let's clear out this. Let's clear out this as well. Okay, so when I give you mycophenolate, okay, mycophenolate is a prodrug. It's an ester. The active drug is called mycophenolic acid. Okay, this drug is absorbed into the portal circulation. Okay, that drug is then taken up by the enterocyte, by the hepatocyte, is secreted with P-glycoprotein into the bile, which is squirted back into the enterocyte and then recirculates. This is called enterohepatic recirculation. So if you look at the drug level of mycophenolic acid, okay, over time in a patient who's not getting cyclosporin, what you'll see with the morning dose is a peak in that drug level and then a second hump. And then your PM dose, a peak and a second hump, okay? So the total exposure to the drug is usually estimated by what's called the area under the curve, okay? When you dose mycophenolate with cyclosporin, you don't get that second peak, okay? So the AUC is reduced. The AUC, when co-administering with cyclosporin, is less, right? You don't have this portion of the AUC. All right, so what does that mean? It means that when you're dosing cyclosporin with mycophenolate, if you want to get the same amount of mycophenolate exposure as a patient receiving tacrolimus, you need to have a higher maintenance dose of mycophenolate, okay? So that might be relevant, including in GN clinic, when you're adding a calcineurin inhibitor to somebody's mycophenolate because of lack of a response. You might consider, well, if I'm giving you FK, I am not affecting your mycophenolate exposure, but if I'm giving you cyclosporin, maybe if you can tolerate it, I need to increase your mycophenolate dose. Okay? Questions about that? No. Okay, so diarrhea can affect calcineurin inhibitor exposure. The general gist is cyclosporin is not really affected by diarrhea so much. If anything, there may be a reduced cyclosporin level that you might see when you're having diarrhea on cyclosporin, okay? But we classically see increases in tacrolimus level when you have diarrhea. And there's some hand waving about why that mechanism, or what is the underlying mechanism for that. I've highlighted some of this mechanism that involves enterocyte metabolism of the tacrolimus through the CYP3A4 system, and also some peak glycoprotein expression that differs from the small bowel, the proximal small bowel to the distal small bowel. Okay, so I won't get deep into that, but if you want to can think about that on your own, I've given you some information there. That's not solid evidence. Okay, but clinically, that's what we see. Tacrolimus levels can often go up when the patient has diarrhea. And so their AKI can often be twofold. It's volume depletion plus tacrolimus toxicity. It's a classic presentation. All right, side effects, which are common to both cyclosporin and tacrolimus, are features of pseudohypoaldosteronism, or Gordon syndrome is the eponym for that, okay? And once again, when we talk about dyskalemias, we'll revisit the role of calcineurin on potassium transport, acid transport, and sodium transport, okay? So again, there's a mechanism behind the hyperkalemia, metabolic acidosis, and hypertension of calcineurin inhibitor. Think Gordon syndrome or pseudohypoaldosteronism type 2. Okay. There is also a predictable hypomagnesemia that happens with calcineurin inhibitors that involves claudins. We'll talk about that as we talk about hypomagnesemia. We will revisit that. If you want to take a glimpse of it, you can go to your tubular transport map. You'll see that calcineurin is in that map. Okay, so it's there. You'll see calcineurin in the pseudohypoaldosteronism in the distal convoluted tubule. You'll see calcineurin in in the effects of CNI. So calcineurin is here as well. Okay, here we are in the distal convoluted tubule. Just a quick, preview. The other things that you'll see that are common to both include insulin resistance, dyslipidemia, hyperuricemia. You can often see tophaceous gout with these, and a risk of thrombotic microangiopathy. Okay, these are dirty drugs. Again, calcineurin is not solely expressed in the kidney; it's expressed everywhere, essentially, and so it may explain why you see all these multiplicity of effects from calcineurin inhibitors. Okay,
Hypophosphatemia.
we don't typically see hypophosphatemia. You do with sirolimus. It's subtle, but hypophosphatemia is not typically a manifestation of calcineurin inhibitor effects. Rapamune, yes, but CNIs, no. Okay, there is a difference between the two. Cyclosporin tends to cause hair growth. Tacrolimus tends to cause hair loss. Okay, so that itself is sometimes why I would not use cyclosporin in females. That's one decision factor. Gingival hyperplasia is a known side effect of cyclosporin, often in combination with nifedipine, which can also cause gingival hyperplasia. Neurotoxicity might be more severe with tacrolimus, as is diarrhea. Tacrolimus is a macrolide. Cyclosporin is not. So if you recall, macrolides can interact with the motilin receptor in the gut and stimulate intestinal peristalsis, explaining why tacrolimus is a cause of diarrhea. We often gravitate, it's your mycophenolate, and we keep, working on the mycophenolate side. But sometimes you'll have patients who just continue to have diarrhea despite the dose reduction in the mycophenolate. You even change them to azathioprine. You have to think about tacrolimus as a contributor there. And so I've certainly had to change people from tacrolimus to cyclosporin because of diarrhea, and usually gets better. It is thought to be more diabetogenic than cyclosporin. There may be a difference in dyslipidemia as well. Some have shown that the dyslipidemia with cyclosporin might be worse than the dyslipidemia of tacrolimus. But diabetogenic, tacrolimus seems to be more diabetogenic than cyclosporin. Okay. Questions about the calcineurin inhibitors? Okay. I think I'll do mycophenolate real quick, just because I'm moving slower than I had hoped. But I think this is a short conversation. Remember, we talked about this being part of that cell cycle arm of intact immune response. It is an antimetabolite inhibiting T and B cell proliferation. It inhibits this inosine monophosphate dehydrogenase enzyme, which is involved in making purines from scratch, as opposed to recycling intermediates to make new purines. So that's your adenine and guanine, remember? So activated lymphocytes seem to depend on de novo pathway of purine synthesis more than, for instance, your hair follicles. So that's why this seems to have more specificity for your immune system, even though it's a global inhibitor of cell cycle progression. You don't typically see, again, hair loss with these drugs. This is, again, mycophenolate is an ester. It is metabolized to mycophenolic acid. This mycophenolate sodium is myfortic. That is supposedly less GI toxic, but I found that most people who can't tolerate mycophenolate can't tolerate myfortic either. Okay. This is a very bioavailable drug. You typically don't need to make any dose adjustments when giving it IV versus PO. It has the enterohepatic recirculation, which I've already reviewed, which is inhibited by cyclosporin. Free levels increase with renal insufficiency. So let's compare and contrast. Cyclosporin and tacrolimus, you don't need to reduce the dose of drug in renal insufficiency. You do need to consider reducing the drug dose of mycophenolate in renal insufficiency. The free levels of the drug seem to accumulate in renal insufficiency, as well as hypoalbuminemia. It's a protein-bound drug. So again, in a patient with severe renal insufficiency and nephrotic syndrome in GN clinic, we may not want to push to 3 grams a day, okay? There may be reduction in levels when you give it simultaneously with some of these minerals. Gastric antisecretagogues might affect the drug absorption. However, this is pretty low level interaction because, again, it's a highly bioavailable drug, so it's pretty subtle. But you can see if you put it in Hippocrates, it'll show, yes, the PPI can affect the drug absorption of mycophenolate, but we usually don't worry about that. Typical doses are 1,000 BID. You can push to 1,500. Mycophenolic acid equivalent dosing to 1,000 BID would be 720, okay, BID. Side effect, the main one is nausea and diarrhea. Maybe there's less of it if you give it more frequently at smaller doses. The intestinal biopsy can sometimes be pursued looking for effects of mycophenolate. They just call it mycophenolate enteropathy. This can look like, interestingly, inflammatory bowel disease. There are these little crypt abscesses that are present. So it can mimic inflammatory bowel disease. You'll have these other features, apoptosis, that also manifest, okay? So they'll just call it evidence of mycophenolate enteropathy or mycophenolate effect. Sometimes you pursue kidney biopsy. Last, real quick, azathioprine. It's also a prodrug. It is, 6-MP, that chemotherapy that you give is the downstream metabolite of azathioprine, okay? These two drugs are metabolized further into these thioguanines, okay? Those interfere with RNA and DNA synthesis, okay? And there are also people have shown, particularly in the rheumatology literature, that there are other effects of azathioprine beyond simply inhibition of RNA and DNA synthesis through its anti-metabolite effects. This is also a purine antagonist, essentially, okay? The important interaction to be aware of are two of them, okay? If you give it with allopurinol, that increases dramatically the effects of the anti-metabolite effects of the drug. So one of the pathways of metabolizing 6-MP, remember azathioprine is metabolized to 6-MP and then on to active and inactive metabolites. Xanthine oxidase is one of those pathways of metabolism to inactive metabolites. So if you inhibit xanthine oxidase, either with allopurinol or febuxostat, you will dramatically increase the toxicity to the marrow. You can cause profound cytopenias, okay? Another metabolism pathway is this thiopurine methyltransferase pathway. Now this has inherited differences of protein activity, okay? There's natural variance in activity in this TPMT. And so there is a portion of the population that has a deficiency in this TPMT enzyme activity, okay? Most of which have mild deficiency in activity. There's a small proportion of patients who have a profound deficiency of TPMT activity. And so you may consider looking for this genetic difference. It's not a defect, it's a polymorphism, it's a difference in activity prior to starting someone on azathioprine. You don't always have to. I certainly have started people on azathioprine and just made sure I checked CBC and liver function tests 1 week later, 1 to 2 weeks later. The typical dose is about 2 mg per kg. Side effects are increased risk of cancers more than mycophenolate, though both can do it. There's certainly increased risk of warts, more so than mycophenolate as well. You can have this idiosyncratic hepatotoxicity. When you check you can check thioguanine metabolites. You can measure that. You can send that as a test. It will give you a multiple thioguanines, including this 6-MMP metabolite, which correlates with hepatotoxicity. There's a literature in particular in the inflammatory bowel disease literature following 6-MMP metabolites as a predictor of of hepatotoxicity. Okay. And this is the preferred antimetabolite in women trying to get pregnant. I would say most people do not change to azathioprine in men that are trying to father children. Okay. Questions about our antimetabolites before we end there?